Hello everyone, today in this video I will talk about the neonatal seizures. Neonatal seizures are due to the underlying cerebral and biochemical abnormalities. It is defined as a paroxysmal alteration in neurological function, that is motor or behavior or autonomic function. In this video, newborn is suffering from severe birth asphyxia with hypoxic ischemic encephalopathy grade 3 and seizures are there. Incidence of the neonatal seizures are 0.5 to 0.8% in term babies and 6 to 12% in preterm babies. Whenever a newborn is having the abnormal movements of the limbs, we have to differentiate it from the jitteriness. So in jitteriness, in this video you can see newborn is having the abnormal movement which is jitteriness, and we can easily differentiate because this movement is aborted by restraining the limb, while the seizures cannot be aborted by the restraining the limb. So in this video you can see movements are still persist even after restraining the limb. So jitteriness movements in the jitteriness are stimulus sensitive while not in the seizures, and movement cease with the restraint in jitteriness, not in the seizures. And abnormal eye movements will be present in the seizure, not in the jitteriness. And quality of the movements will be just like a tremor in jitteriness, and in seizures just like a clonic jerk. Types of neonatal seizures are subtle seizures, which are most common, clonic seizures, tonic seizures, and myoclonic seizures, which are very rare. So in this newborn, subtle seizures are there. These are the commonest type of neonatal seizure, constitute about 50% of all neonatal seizures. And in subtle seizure, clinical manifestations are mild and frequently missed. So in this video you can see the newborn is having the subtle seizure, having frequent eye movements. So in eyes, tonic horizontal deviation of the eyes or sustained eye opening with the ocular fixation or cycled fluttering or jerking movement of the eyes can be there. In this video you can see the newborn is having the sucking and chewing movements. These are also the subtle seizures. So oral, facial, lingual movements in the form of chewing, sucking, lip smacking are the form of subtle seizures. Subtle seizure can be present as a limb movements in the form of cycling, paddling and boxing, as is present in this newborn also. Autonomic phenomena, tachycardia, bradycardia can be there, and in term babies it can be manifest with the apneic attack also. So subtle seizure can be manifested in the form of eye, orolingual, facial movements, limbs movement, autonomic phenomena or apneic attack. So if the preterm baby is having apnea with the bradycardia, we will say patient is having apnea of prematurity. If apnea is associated with the tachycardia initially, we should think about the seizures. Now second type is focal clonic seizures. In this video you can see the newborn is having the focal clonic seizures. They are rhythmic movement of a muscle groups. It can involve the face, upper or lower extremities on one side. Now multifocal clonic seizure can be a presentation. In this video you can see the newborn is having multifocal clonic seizure in the lower limb, upper limb, and facial movements are also there. So it involves the several body parts and often migrate in a non-Jacksonian manner. It may also involve the face. So in this video, you can clearly see multifocal clonic seizures are there. Rarely, tonic seizure can also be present in the newborn. They may be focal or generalized. It may resemble the decerebrate or decorticate posture. And prognosis of the tonic seizure is very poor. And it's generally associated with the intraventricular hemorrhage or connectrus. It is usually associated with the apnea and upward gaze of eyes also. Myoclonic seizures are also very rare. In this, sudden jerky movement are produced by the episodic contraction of a group of the muscles. So in this video, you can see the newborn is having the sudden jerky movement. And we have to differentiate these movements from the clonic. So in myoclonic seizure, they are manifest as a single or multiple lightning fast jerk of upper or lower limbs. And we can distinguish from the clonic movement because of more rapid speed of the myoclonic jerk and absence of the slow return. While in the clonic movements, comparatively, they are slow and return will be slow in the clonic jerk. Causes of neonatal seizure. There are various causes of neonatal seizure. Hypoxic ischemic encephalopathy is the most common cause of the neonatal seizure. After severe birth asphyxia, newborn develops hypoxic ischemic encephalopathy and convulsions are present in the grade 2 HIE, and it is most common cause of neonatal seizure present in 60% of the newborns. Second cause is it can be due to the infections, pyomeningitis or meningoencephalitis in torch infection. Metabolic disturbance can also causes the neonatal seizure. This is second common cause. It can be due to the hypoglycemia, hypocalcemia, hypomagnesemia, pyridoxine deficiency, or rarely inborn error of metabolism can also lead to the neonatal seizures. So in this video, you can see the neonate is having the intracranial hemorrhage and developing the seizures. So due to the intracranial hemorrhage, seizures can occur in the neonate. And if the neonate is having the seizures on the full term, neonate is having the seizures on the between second day to seventh day of life. Otherwise, there is a no history of birth asphyxia. You should rule out the intracranial hemorrhage. Developmental defect, example cerebral dysgenesis, neuronal migration disorders, lysencephaly can also lead to the neonatal seizures. Investigations for the neonatal seizures are blood investigations, complete blood count and C-reactive protein to rule out the infection in the newborn, blood sugar to rule out the hypoglycemia, serum calcium magnesium level for hypocalcemic and hypomagnesic seizures, serum sodium because hyponatremia and hypernatremia both can lead to the seizures, potassium serum bilirubins. In connectrus also newborn can develop the seizures, serum ammonia, blood lactate level and ABG analysis to rule out the inborn error of metabolism, blood culture and sensitivity for infection sepsis in the newborn. CSF analysis, biochemical test, culture and sensitivity to rule out the meningitis, meningoencephalitis in newborn. Cranial USG, electroencephalography, EEG should be done, and if required, if you are suspecting intracranial hemorrhage, then CT brain will be required, MRI brain to see any malformation in the brain or any hemorrhage or any changes of the hypoxic ischemic encephalopathy can be find out in the MRI brain. Now the management of neonatal seizures. Secure the airway, optimize the breathing, circulation and temperature. So ABC. Then start the oxygen if seizures are continue in spite of giving the anticonvulsant. Secure IV assist, take the sample for the baseline investigations. Whenever a newborn is having the seizures, first investigation is the blood sugar measurement. So if the sugar is less than 40 milligram per dl, we will label as a hypoglycemia, and we have to administer 2 ml per kg of 10% dextrose as a bolus, followed by the continuous infusion of 6 to 8 milligram per kilogram per minute. If blood sugar is in normal range, then sample for the ionized calcium should be withdrawn, and if it is abnormal, less than 7 milligram per dl, then 2 ml per kg of calcium gluconate should be given IV under continuous cardiac monitoring. It is state dose, then 2 ml per kg 6 hourly will be continue for next 2 days if the calcium level is low, less than 7 milligram per dl. If convulsion persists after correcting the hypoglycemia and or hypocalcemia, injection phenobarbital 20 milligram per kilogram loading dose IV given over a period of 30 minutes, 1 milligram per kilogram per minute rate. In phenobarbital vial, 200 milligram per ml is the concentration. So after doing the 1:9 dilution, weight equal to the ml will be the loading dose. So 20 milligram per kilogram will be the loading dose, should be further diluted in the normal saline and given very slowly over a period of at least 30 minutes or up to 60 minutes. And we have to observe or wait for at least 30 minutes. If convulsion still persists, we can repeat the injection phenobarbital in 10 milligram per kilogram per dose liquid until 40 milligram per kilogram total dose is raised, and after that maintaining dose of the phenobarbital after 12 hours will be started 5 milligram per kilogram per day divided in BD doses. If the convulsion persists after giving the phenobarbital, we can give the phenytoin. Dose of the phenytoin is similar to the phenobarbital, 20 milligram per kilogram loading dose IV given over a period of half hour, and the concentration of the phenytoin in absolute injection is 50 milligram per ml. So we have to give 20 milligram per kilogram loading dose, and we have to wait for the 30 minutes. If convulsion still persists, we can repeat the injection phenytoin in 10 milligram per kilogram per dose as a half loading dose, and it is followed by maintaining dose of phenytoin 5 milligram per kilogram per day BD and phenobarbital 5 milligram per kilogram per day BD should be given alternatively and 12 hours after the loading dose of pheno and phenytoin. If the convulsion still persists in the newborn, then injection lorazepam 0.05 to 0.1 milligram per kilogram IV is administered, or we can give midazolam 0.02 to 0.1 milligram per kilogram IV. It should be followed by infusion of 0.1 to 0.4 milligram per kilogram per hour. We should not use the diazepam because it is not safe in the newborn as it interferes with the vital function. Respiratory depression will be the dangerous side effect of the diazepam in newborn, and its sedative effect half-life exceeds the 24 hours. So we should not use the diazepam in newborn. If after giving the phenytoin and lorazepam or midazolam, still convulsion persists, consider the ventilation, intubate the patient and give the proper ventilation, and we will label as a refractory seizures. Then we will start the other treatment. So in this lidocaine 10 milligram per ml concentration is available. In this bolus dose of 4 milligram per kilogram IV, which is followed by infusion rate of 2 milligram per kilogram per hour. But we should remember lidocaine should not be administered with the phenytoin. Whenever we are starting this drug and patient is having refractory seizure, we should stop the phenytoin. Otherwise, complication will develop. Or we can give the paraaldehyde per rectally 0.3 ml per kg per dose, which is mixed with the coconut oil in 3:1 dilution. Or we can give intramuscular also 0.1 to 0.2 ml per kg per dose if patient is not responding to the lidocaine. If still seizures are refractory to the above treatment, we can try the sodium valproate injection, in which 100 mg per ml concentration is available. Loading dose of valproate is 20 mg per kilogram. It should be followed by 5 mg per kilogram per dose divided BD IV. Or if patient is not responding, then vigabatrin, which is available orally, or topiramate injectable preparation is available, can be given to the newborn. If seizures are refractory to above treatment, then we should suspect patient might be having hypomagnesemia, which can be treated with the 50% magnesium sulfate 0.2 ml per kg intramuscular. Rarely patient may have the pyridoxine deficiency or the congenital defect in the pyridoxine metabolism. We say pyridoxine dependency. In this 100 milligram intravenous pyridoxine can be given. If it is not available, then 1 ml of Neurobion, which contains 50 milligram pyridoxine. So 1 ml each may be administered IM in both the side of the thigh in anterolateral aspects. Severe side effects of the pyridoxine is it can causes the severe hypotonia, bradycardia or apnea can develop. So we have to be very careful. If patient is having refractory seizure in spite of all these drugs, we should suspect inborn error of metabolism and we can go for exchange transfusion. Now the duration of anticonvulsant therapy. How long should we continue the anticonvulsant once we have started? So in neonatal period, we have to taper the drugs one by one. If which drug we have started last should we stop first, and if the neonatal neurological examination become normal, we can discontinue the all anticonvulsants, but should be slowly and step by step. If we have started phenobarbital and phenytoin both, we will first decrease the phenytoin, then we will stop the phenytoin first, then we will decrease the dose of pheno, then we will stop the phenobarbital. If neonatal neurological examination is persistently abnormal, then consider etiology and obtain the EEG. Patient might be having the some changes in the brain which can be seen in the EEG. So continue the phenobarbital and re-evaluate the patient after 1 month. And if EEG is abnormal, we can continue the phenobarbital up to 3 months of the age. 1 month after discharge, again neurological examination has to be performed, and if it is normal, we can discontinue the phenobarbital. If neurological examination is persistently or abnormal and EEG is also suggestive of some seizure activities, then we can continue the phenobarbital. If no seizure activity on EEG, then we can discontinue the phenobarbital. Prognosis of the neonatal seizure is related to the etiology. So if the newborn is having the severe birth asphyxia HI grade 3, then the prognosis will be that 16 to 50% newborn will have the normal development. If early onset hypocalcemia is the cause behind the neonatal seizure, then 50% newborn will have the normal development while the 50 will have the abnormal. Prognosis of the late onset hypocalcemia is very good. 100% normal development can be there in late onset hypocalcemia. In hypoglycemia, 25 to 50% newborn will have the normal development while the 50 to 75% will have the abnormal development. And in hemorrhage, if hemorrhage is intraventricular, which is common in the preterms, prognosis will be very bad. Only 0 to 10% newborn will have the normal development. In subarachnoid hemorrhage, which is common in the term baby, 85 to 90% will have the normal development. So again, prognosis is good in subarachnoid. After pyomeningitis, 25 to 65% will have the normal development. And prognosis is very worse if the newborn is having developmental defect. Hardly 0 to 5% will have the normal. Thank you so much.